how AI can strengthen disease surveillance, improve outbreak prediction, optimize health system planning, and expand access to diagnostics as well as health information, health insurance, and so on. Advances in deployable AI models and computing infrastructure now actually makes it very much possible to run real-time analytics and locally contextualized tools closer to the point of care. I'm sure people have visited the expo, and I'm sure you've seen a lot of these point of care devices, point of care diagnostics, and I think those are all very exciting things which are happening in this particular era. However, scaling AI within national health systems and national health programs in particular, right, that still remains slightly complex. And there are challenges, right? And those challenges include one big time challenge is fragmented data systems. We still have fragmented data systems. We still have challenges with respect to governance frameworks. We have challenges with respect to procurement. We have challenges with respect to capacity of compute, and probably the most important, people, right, who can actually use these devices, use these solutions at the time of service delivery. And last but not least, and we touched upon some part of this during the sessions as well, is sustainable finance. How do we ensure that we finance these solutions? In this session today, what we're trying to do is to see how we can figure out a way to responsibly embed AI into national health systems, national health programs, and deliver measurable population level impact, right? This discussion will try and touch upon the institutional as well as ecosystem enablers and that which is required for scale, right? So this, we will probably touch upon interoperable digital health infrastructure. We'll talk about how some of the solutions can go up to the last mile, primary health centers, community health centers, how we try and incorporate that, how do we really build capacity of the workforce, and so on. That's what we're trying to address through this particular session. I'll get into the speaker lineup that we have. We have a wonderful panel. Dr. Sunil Barnwal, when he joins, we will introduce him, but AI has not yet solved for traffic challenges, so we are yet to solve that. Until such time, let me start with Amit. Amit looks at AI products at NVIDIA. Pleasure to have you, Amit. Amit is an AI leader at NVIDIA, driving the adoption of agentic and generative AI across industries. With over 15 years of experience blending research, engineering, and enterprise strategy, he helps organizations architect and scale intelligent systems with real world impact. He's an IIT Guwahati alumnus and a Stanford scholar. He has worked with Google, HP Labs, VMware, EFI, and holds 6 patents in AI, NLP, and Industry 4.0. He combines deep technical expertise with leadership in shaping the next wave of enterprise AI transformation. Pleasure to have you with us, Amit. We have Dr. Sabin Kapasi, who's the CEO and Managing Director of Enira Consulting. Sabin is a globally renowned healthcare strategist, extensive multi-country experience, having worked across diverse healthcare systems worldwide. She has led initiatives in varied regulatory and policy environments, enabling her to design solutions that are adaptable across geographies. Her work focuses on developing innovative medical technologies aimed at reducing hospitalizations and improving patient outcomes. She integrates finance, technology, and healthcare delivery models to build sustainable, scalable systems that promote accessible and high quality care. I was actually looking at her LinkedIn profile. It's amazing the kind of work that she has done. So great to have you, Sabine, amongst us. Siddharth Panwar is founder and CEO of NeuroDX AI. Siddharth is an alumnus of Stanford and IIT Delhi. He is an assistant professor at IIT Mandi and the CEO of NeuroDX. He trained as an electrical engineer and former circuit designer at the United States. He transitioned into neuroscience to develop computational and signal processing tools for diagnosing epilepsy, right? And I don't know how many of you have worked in the remote hinterland of the country and even in other places. Epilepsy is a huge taboo, and the kind of treatments that are done for epileptic patients just unbelievable, right? So I think this is a great AI solution that we have with respect to addressing epilepsy. His academic work spans neuro AI, including building diagnostic models for electrophysiological data, studying memory mechanisms in rodent models, and exploring neural representations through the fruit fly connectome. At NeuroDX, he is currently leading the effort to build foundation models for the brain and next generation clinical decision systems. NeuroDX is a part of the India AI mission, where his team has been tasked with developing sovereign foundation models intended to power future healthcare, neurotechnology, and scientific innovation in India and beyond. Pleasure to have you with us, Siddharth. He also has a booth in the AI Expo, so some of you who want to visit, please do take a look. Dr. Anunaya Jain, our next speaker, Global Technical Director, Digital and Data Analytics Hub Digit at Japaigo. Good friend of mine, AJ, as we all know him. He's an emergency physician by training and has transitioned into now an experienced digital health strategist. His goal is to fix systems and drive impact at scale through technology, through AI. Over the last 2 decades, he has been designing and scaling health technologies that bridge public priorities with private sector execution. From building India's first virtual case simulation learning platform to deploying AI tools across maternal and HIV care and LMICs, he has worked across India, Southeast Asia, Middle East, US, and to turn complexity into scalable, sustainable solutions. Today, he operates at the intersection of health systems, product strategy, ethical AI, driven by a belief that scale and trust must go hand in hand. Great to have you with us, AJ. So we'll get into the questions while Dr. Banwal comes to the dais. But let's begin. So we'll try and have 2 rounds of questions to the panelists. And then if time permits, we will open it up for the audience to ask hopefully 2 or 3 interesting questions. So let's begin with Amit. Yeah, great. So NVIDIA's platforms like NeMo, which is for building, deploying, and optimizing agentic systems, and NIM, which is NVIDIA Inference Microservices, they are being used to build scalable, multilingual AI applications. My question to you, Amit, is how can such tool chains be adapted to support secure, locally relevant disease predictions and diagnostics at the edge in rural or resource constrained settings while ensuring privacy, data sovereignty, and performance as well?
Yeah. Okay. So thank you so much for the introduction and the content.
I don't think it's working.
Yeah. Is it audible?
Yeah.
Okay. Thank you so much. So yeah, to your question, so NVIDIA, what we are doing right now in the country in the form of India AI mission, NVIDIA is a key partner of government in the AI mission, and what we are doing is that we are helping enabling sovereign foundation model builders. So the tools name which was mentioned, NEMO, NIM, what they do essentially is that we enable everybody to build the platform with sovereignty so that your model stays in your control, and that is pretty much important for the healthcare sector because the DPDP Act, that is, and the privacy matters a lot, right? You don't want your data to be going outside, right? So essentially, what should happen? The model should come to data rather than data going to model. That's pretty much relevant for the healthcare. So NVIDIA has built all these tools, software-wise as well as hardware-wise as well, so that in the resource-constrained area, rural areas where you don't have, let's say, very good, I would say, connectivity, in that area also it can run as an edge device, right? I would 2 example I would give you. One example is that currently what we are doing, we are working with some of the partners to build the multilingual transcriber because India may we have zero point 0.7 doctors over 1,000 population. WHO recommends at least 1,000, right? Now, doctor-patient conversation, just by documenting, it takes a lot of time. Essentially, it lists 15 minutes, 20 minutes, and doctor spends 10 minutes in just documentation. The whole that process has been automated now. So they will simply talk, and it will go in passes the EMR data, and that's how we are increasing the productivity of doctors. Yeah. So that's one part of it. Then obviously you have X-ray and pretty much disease prediction, and NVIDIA has all these platforms models which actually helps to build the forecasting of a disease spread as well, I would say, and that's very relevant because healthcare data we have to build model on our data set because genetics is different, right, worldwide. So yeah.
Great, great. Thank you, Amit. I think very important to know that the platforms can be used by different kinds of people, and then they can develop tools on top of it. So maybe that will take us to what Siddharth has been doing. And your team at NeuroDX is building AI models, right, that interpret human biosignals for early detection, monitoring, and diagnosis of health conditions. And in the context of population health, how can such biosignal based AI tools be embedded within national health platforms and programs to improve early detection and continuous monitoring, right? So, again, as I said, epilepsy, big problem, but how does it really translate into work in at the front line of where patients are, right?
Yeah.
Would love to hear your thoughts on
Yeah,
that.
that's a great question, actually. I hope I'm audible. Epilepsy is one disorder which actually also suffers from a lot of stigma and superstition around it, right? And so, diagnosing it correctly is a big step towards making sure those who are suffering from this disorder come into the network, the medical network, the network of doctors, and then eventually get treated. So the challenge that you most often see with what some of the AI engineers are often trying to do is try to replicate what a human doctor can do. But what, for example, we are doing is not just trying to replicate what a human doctor can do. It's looking deep inside signals which have some sort of a diagnostic value in them, which escape the human eye. So with this, what you're doing is you are not just making sure there is another doctor in the form of an AI model in your front lines, but a tool which is far beyond it as well, right? So some of these disorders cannot be very easily diagnosed even in the best of facilities. So making sure that that happens very inexpensively is the primary engineering challenge that we have taken on. And coming on to the specific question that you asked, now that you have that technology, that is perhaps even better than, or not, I wouldn't say better, has an ability that human beings don't have to be able to look into certain kind of data and find things from it, find patterns from it. Now that you have that technology, how do you deploy it so that everybody gets the benefit, right? And so the challenge that I see, for example, if I'm at IIT Mandi, I'm a faculty at IIT Mandi, and in Himachal, I have to actually drive down to Chandigarh to find a neurologist. We have, I think, maybe 2,500, 3,000 neurologists in the entire country. So it's a very large population that you have to serve. So if we can actually get those people who need serious specialized help screened from the population, from the front line, and get them directed to the right people, right clinical services, that will go a long way. So what we are thinking of, this is what something I also kind of presented to the Prime Minister. We were fortunate enough to present our work to the Prime Minister recently. So what we kind of envisage is that we place these very inexpensive tools in these primary healthcare centers, something like these Arogya Mandir, Ayushman Arogya Mandir, which are at the front lines. And you can, if you can screen them with some sort of you don't have to diagnose them right away. If you can screen them successfully as somebody who needs to be looked at more seriously, then there are platforms like eSanjeevani that the government has built, which is a referral platform, right? You can have then neurologists have a look at it. And then there is Pradhan Mantri Jan Arogya Yojana, which is the insurance scheme. So if something is found out, then they can be supported for treatment, right? So we are hoping to fill that gap, which connects a lot of infrastructure that already exists through technology, right? And so existing resources can be made world class if you fill the right gaps, technological gaps.
Yeah, yeah, that's a great point, Siddharth. And I think we looked at platform, we looked at tools and its implementation. Maybe we'll go to Dr. Sabine now, and we'll try and see how we can look at equitable and safe usage of the tools and the platform. So, digital health and innovation, we know that they must work for everyone, especially those at the margins, vulnerable communities. We have women and children. We have people with who come from tribal backgrounds, rural areas, remote locations, underserved communities, all of these. And in the context of population scale AI, what would be important is to figure out how governments and private organizations can work together to address equity and safety right? When we are delivering services and we are providing AI solutions. Over to you, Sabin.
Thanks a lot. See, before we jump into how platforms and tools or devices should function ideally, let us first, understand a very simple distinction between screening and testing. We have been talking about screening a lot, and I'm sure a lot of you are from the healthcare background. I'm hoping so. Otherwise, I'm great that you are here, grateful that you're here. But screening means to precede symptoms, to actually test someone before they feel that there is something wrong with them. So that is what is the definition of screening. The test can pretty much be the same test which you do for the people, but when you do it at a stage where the patient still does not think that there is a problem, or it is just before they start showing symptoms, is what you call screening. Now, screening, our body becomes a new body, almost a new body apart from our nervous system, once every 120 days. So the point is that screening is something that needs to happen recurrently, over and over again, continuously, and it should be at a in a framework where it is accessible to everyone, because COVID showed us very, very clearly that if you are safe in your own bubble but people around you are not, then you are still at a significant risk. So health by definition is an all or none game. Either everyone gets access to health or almost no one is completely risk free. So these are a couple of principles that first we need to understand. Now, looking at these three things, what do we look at in terms of safe as well as equitable solutions in both tech and in screening systems? I think today the kind of access that we have to building new technologies should actually be applied. Sorry, am I still audible? Yeah. Should actually be applied to something called need assessment. It's a very business principle, right? What is the need that you're trying to solve? So, uh, like we just
Can you please
Hello.
stop there?
Yeah,
Yeah.
maybe it's fine. So, like we just discussed, epilepsy is one example, and women's health is another big example where access to more than 51% of the country to healthcare is fairly limited. People don't speak about a lot of challenges that they have. So, creating a framework of frontline workers, which India has done fabulously well, right? Our AAA network is one of the best in the world. Anchoring AI tools for them so that they are mobilized to do recurrent screening, and then of course expand that into a very structured referral system, which it was always intended to be. So when we say referral, it means that only the people who need secondary care or a doctor is going to go to a doctor, and only the people who need tertiary care is going to go to a tertiary care center, and so on and so forth. The reason why this is important is, as you rightly mentioned, specialists and super specialist doctors are always going to be low, right? Just because that is how the system is supposed to be tired. You are supposed to have more GPs on the field, you are supposed to have lesser and lesser number of specialists, because that's how the need is supposed to be structured out. So I think that is where a safe secure system can be built out, where we start with the frontline workers, look at recurrency of care delivery, and then build on top of that as a structured system. I think when these principles are followed to the T, which I think we are trying to with systems like Ayushman Bharat Digital Mission, as well as we are attempting the same at a scale, and we are succeeding very well with PMJY. So anchoring financial systems on top of that is going to be the two ways that we execute it very, very effectively. And I think these are the two things. And I think now that we have our esteemed guest coming in as well, it is a good segue into this.
Yeah.
So I think India has done this very well, and as more and more healthcare systems adopt to these two programs, we are going to anchor the recurrency of care delivery and the ground up approach of it very, very effectively.
Dr. Banwal, pleasure to have you, sir. We're sorry we had to begin, but I had promised that that once you're here, we will introduce you, and actually you've come exactly at the right time, because we were just about speaking about how some of these solutions get anchored into the ABDM track as well. So, Dr. Sunil Kumar Banwal is the CEO of National Health Authority, Government of India. He's a distinguished IAS officer of the 97 batch. He secured the first rank in the Civil Services Examination in 96 and was conferred the Director's Gold Medal at Labasna for achieving the highest merit in his IAS batch. He holds a PhD in management from IIT Dhanbad, a BTech in petroleum engineering from IIT Dhanbad. He has a master's in public management from NUS Singapore and Harvard University, and an NLB from Ranchi University. And so that's like really, really amazing credentials. Anyway, so as CEO of NHA, Dr. Banwal leads the implementation of two of India's flagship health initiatives, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana and Ayushman Bharat Digital Mission. The NHA is responsible for the national rollout of both the schemes, while the state health agencies manage their execution at the state level. Under his leadership, the NHA continues to advance digital health infrastructure, expand coverage, strengthen service delivery, and is now very seriously figuring out how AI is reforming and reshaping the entire architecture. So while we started off, sir, we discussed a little about the platforms, the tools. We spoke about how marginalized communities can benefit from this, and we were just about entering the component of how AI and AI tools can engage with the ABDM architecture, sir. So over to you. The question really is to look at what are the ways in which um, secure AI solutions can be scaled for population health, and how can the ABDM's foundational digital infrastructure be best leveraged?
Yeah,
Over to you, sir.
so thank you, and I apologize for being late. I think there are quite a number of people you have to pass through. Uh, but anyway, let me express the kind of work being done for creating digital foundation for leveraging you know uh, emerging technology, including AI, for healthcare transformation. You have already mentioned that NHA implements world's largest health assurance program in form of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which caters to bottom 40% of the population. It covers almost 60 crores families. And if you see the size of its implementation, every month 20 lakhs claims are being processed. It means 20 lakhs patients are being treated across a network of 35,000 hospitals, in which about 50% are private hospitals. So till date, 110 million, more than 110 million patients have already been treated, and the value of it is almost 1.7 lakh crores. So this is the volume at which we are working, and this is all possible only because we have a very robust IT platform on which this scheme runs. So this is one part. More than that, we have built a digital infrastructure in form of Ayushman Bharat digital mission. And this is a digital public good because it is open, interoperable, and it is federated architecture. So here is the architecture which acts like an infrastructure on which actually rails have to run. So we have created the rails, and the trains will run in the sense this architecture allows every facility, be it hospital, be it pharmacy, be it laboratories, to onboard through the verified registries. And verified registries are registries of health facilities, registries of health professionals, and registry of patient in form of Aadhaar ID. Here also, if you see the volume of it, 86 crore citizens have got the Aadhaar ID. More than 4 lakhs facilities are already registered, which gives them the verified credentials. And more than 7.5 lakhs professionals are also registered, which you can take as a verified identity. With these registries, we actually enable two things. One, quality of the data which gets created through this digital system, and second, the trust it builds. So whenever you are interacting with the hospitals or the laboratories, you are very sure that you are interacting with the facilities of right credentials, professionals of the right credentials, and therefore keeping patient in the center. Actually, these digital health records which gets created can be exchanged, can be actually shared across the facilities with the consent of the patient. Now, given this architecture, what it does, it has created the digital foundation which makes the healthcare delivery more connected. And now, once you have a connected health system, which was earlier more fragmented because it was more in form of a episodic incident, that you go to one hospital, you get the record and it remains there. Next time you go to the hospital, you don't have anything except you carry the physical copies which may or may not be used. So now with ABDM, you have a connected health system. So, when you think of or talk of applying artificial intelligence, it can only be applied if the systems are connected or integrated. Else, it will also have a standalone applications. Now we are looking at the AI applications as an additional layer over the data layer which has been created through the ABDM. So this additional AI layer will actually be a solution which can be scaled up to a population scale. And that is how this digital architecture in form of digital public good has been created to leverage AI solutions at population scales. And now it becomes easy. If more and more facilities come on ABDM, they become part of the leverage of AI solution. And that is how, if you see, many of the public hospitals are now using a scan and share for bypassing the queues and getting the appointments. You see the speech to text for the patient doctor conversation are now getting inbuilt into the system because it can work as a layer on the architecture which we have created. Similarly, many more applications can run like clinical decision support systems, etc. So ABDM has actually enabled India to leverage AI solutions at population scale. So instead of going in bits and pieces or making standalone efforts, here is the system where if you are onboarded, you can actually avail the AI layer which gets built over and above this. So this is how I think NHA is trying to leverage this.
Yeah.
And if you see, to build the in fact, to build a framework where AI can be deployed at population scale, yesterday only we have released with in presence of Honorable Health Minister the strategy for AI in healthcare for India, SAHI. And this is the framework by which responsible AI deployment can take place, which will be safe, ethical, and accountable.
Yeah.
It is the framework in which governance is by design, and we are insisting, and the solution actually encourages to keep human in the loop while AI solutions are deployed to give probabilistic solutions. So that is how actually we are moving in deploying AI at population scale.
Thank you, sir. Thank you. Wonderful. Uh, Moving on, I think one of the things that we've been discussing is introduction of AI in the national health programs, right? You can take MNH, you can take infectious disease, you can take any of the national health programs. How do we really try and incorporate AI solutions? And as we know, AI now is such a dynamic field that what you do today is already old tomorrow, right? So, how do you ensure that you create a mechanism to incorporate AI solutions and do this on a regular basis into our national health programs? AJ, your thoughts?
So, thank you. Thanks for that question. And it's wonderful to listen to everybody on the panel as well, because there's so many different thoughts that emerge out of this, right? Right from tools to platforms to actual solutions and then the frameworks themselves. I think the way that we've always thought about this problem is to break it down either into the micro problem that there is that you need to solve and the macro problem that you need to solve, right? And so I'll start with the macro. The first and foremost thing is discovery, right? You have a maternal newborn health program. What is the right solution set that exists out there, and how do you really recognize which ones are the ones that are right for yourself, right? Now, in order to solve for that, you obviously need to first define what is your priority, right? Is identification of high-risk pregnancies your priority? Is preventing mothers from dropping off from the antenatal care visit continuity your priority? Is making sure that you are able to get the right commodities available to them wherever they're getting care? Is that the right priority? I think first is prioritization and making sure that you have your priorities set right? Another tailwind that gets added to this is how ready are your people, right, in order to really be able to do this. And so what does it really take in order to make sure that the workforce capacities and capabilities have been built up so that they can continue to interact with these technologies themselves or are prepared to interact with these technologies themselves. And the third one, and perhaps even more importantly than all of these, is the process itself, right? How are you going to incorporate these solutions inside the platforms, inside the data systems that are present today or that are being built today, right? Now, all of this sounds abstract, right? And so perhaps I'll give 3 or 4 examples to just bring it a little bit back to ground, right? So I'll start with Nigeria, right, where we work quite a bit on HIV, right? The real concern in Nigeria was people are dropping off and discontinuing treatment for HIV, okay, right? And so then building a machine learning algorithm that is able to predict from routinely collected data as to which patients are more likely to drop off and less likely to drop off became a great opportunity. The algorithm was developed because Nigeria has a lot of technology infrastructure constraints. And so at every facility, the model is deployed locally, right? And so the model keeps running at the local site itself. And our measurement now shows that where we've deployed the algorithm compared to control sites, there is a 4 times reduction in interruption in treatment. What succeeds is not the algorithm, right? Let's also be very clear, right? What is going to succeed is not the algorithm. What's going to succeed is the process that surrounds the algorithm. So the intervention set that the health workers are now capable of taking or have been trained on in order to make sure that those interventions are appropriately addressing the interruption in treatment becomes right? And now similarly, right? We talk about this multitude of data platforms. Very soon, we're going to start talking about this multitude of AI algorithms as well, right? One of the things that we're trying in Mozambique is why should there be independent access to each one of these algorithms? Why can't we centralize it? So we're working with a partner there to offer AI over voice. And so it's a single phone number that you call, and you can ask it anything. You can ask it where to get a loan, where to get your bicycle repaired, or what to do because your child has fever, and it'll give you the answer. It just has back-end segregation into it with multiple models where the right answer is coming back to you, right? Similarly, in India, where we're now starting to look at how do we really deploy an LLM solution to summarize what's happening in maternal and child death reviews, right? Universally in India, or in most places, you'll have in every district, there's a meeting that happens every month. You have 2 maternal deaths that are reviewed every month, right? Why can't we do it for all? Yeah. Right. It's the simple application of running a meeting summarization or a summarization tool to really lead to that, right? So it's understanding what is important for the particular individual, the particular owner, the particular health system to really solve for first, and then surrounding it with some of these accelerators. I'm leaving aside the governance and the safety and the dollars, etc. for it. You've rightly mentioned all of those. But I think it's surrounding the tailwinds around these solutions that really leads to a little bit of success, but backed by discovery first, right? So
Cool. Thank you, AJ. I think in the interest of time, maybe I'll have time for just maybe one more round, and that also with great difficulty. But I want to touch on the compute capacity that Amit, that you may want to address, because one of the bottlenecks is the compute capacity. So
Sure.
how do we really look at regional compute capacity? How do we try and figure out local deployment that AJ was speaking about
Yeah.
through the compute capacity that you can bring to the table?
Right. So first of all, just taking some of the data points that so you mentioned. Um, on the DPI side, I'll talk about first the volume. On the DPI side, let me take the example of UIDI, which definitely we are working together with NVIDIA, and we are handling m- 700 million transactions per day. Sorry, 50 million transactions per day. So we understand more in crore, so 5 crore transaction uh, per day. Same with NPCI. NPCI, the volume of transaction is 700 million, that is 70 crore single day, and that is backed by NVIDIA's infrastructure, NVIDIA's software, and because and it's all local because UIDI data cannot go beyond India. Similarly, NPCI data cannot go beyond India. Now, as sir rightly mentioned that since now our healthcare system, as a system wise, now earlier it was fragmented, now it is now unified or being unified, right? That makes it AI ready now. And as you rightly mentioned, ASR, speech recognition, clinical report system, are kind of making co-pilot for doctors, so that if one doctor is able to like let's say talking to patient for 15 minutes, right? And with the help of AI, he can just get this in 5 minutes. He doesn't have to do all this writing and all that, right? So with those all data lake in place, we can have multitude of application which can build. Now coming to compute part. So compute part, definitely government of India and NVIDIA has partnered via India AI mission. That is more of a centralized compute because via NCPs, IOTA, TCL, they have the data center. But now in the healthcare, the challenge that we have seen it, even that is not sufficient. They want pretty much local compute. So for that purpose, I would say we are producing in a large manner something called DGX Spark,
Mhm.
and that was the gifted by Jensen gifted to Elon Musk, and if you open AI, Sam Altman. So this is essentially a AI super box. It
Mhm.
comes in hand, so that every taluka level hospital can have that device,
Okay.
and that will run as a service. On that device will run as a server,
Okay.
and and you can deploy 5 6 GenAI enabled application on that, so your data is secure. CIO is not bothered about DPDP Act and the consequences, right? So that's the solution that we're pushing, so that is bringing healthcare on the edge. Yeah.
Wonderful. Wonderful.
Thank
That's
you.
a great example. Thank you. I have one last question for Dr. Sabine. In terms of regulatory frameworks, we probably didn't discuss that much, right? What governance and regulatory frameworks would be essential to ensure secure, privacy preserving AI deployment while we still maintain innovation agility, right? We want to continue to innovate, but then we also need to have regulatory frameworks in place. Any thoughts on that?
Thank you so much. I think that's a very, very relevant way to look into it. Um, Before I go into that, I want to mention a couple of things because that will add
Sure.
the structure to it. One is that, as you mentioned earlier, the work that I have been doing for the last 20 years, and we have joining in, has actually been around reducing hospitalization or reducing the need for healthcare. So, healthcare primarily as a system.
Use this. Probably this is better.
Okay, I am I more audible? Okay. So healthcare primarily is a system which is designed to disappear, right? You should not need hospitalization. You should actually not be unhealthy. And that's the goal of the healthcare system.
Yeah.
Now, whatever we are doing are steps in that direction, very effective steps in that direction. Now, when we keep that entire core in mind and design a governance framework. So I think what the government has done, apart from ABDM with PMJ, in creating a financial framework around rewarding better health outcomes And I think that is where we are creating a governance framework around it to make tech more people centric. Right. So, what Ananya sir just mentioned here in terms of need assessment, that what there is a movie you guys, most of you would have seen called Three Idiots. There was a dialogue in it, कि कहना क्या चाह रहे हो? I think very, very successful meme as well. But the point is not that. The point is कि करना क्या चाह रहे हो? That is to be extremely crystallized. The need assessment needs to be extremely crystallized, as he mentioned earlier. And then when we add a financial layer to it of incentivizing better outcomes, that is when the right governance framework is set to create tech which is rewarded for better health outcomes. And that is, I think, a one liner master key that we need to use, that whatever we build needs to get rewarded through better health outcomes. If that is not happening, then neither the tech is successful nor the governance system.
Sure.
Right.
Thank you. I have one or two questions with me, but I feel that maybe audience questions are a little more interesting. I hope that's okay with all the panelists. Yeah. Thank you. So, yeah, gentleman in the back. Let's see the one in the end. Yeah. Probably take two questions. We have maybe another 7-8 minutes, so we should be able to take. Yes, sir. Maybe you can quickly introduce yourself and then the question.
Sir, my name is Yadu. We run a DPDP compliance advisory shop. I think the gentleman there mentioned about DPDP. It's all very good to get the overlay of so-called artificial intelligence, and I use that word very directly. The question is very specific. When the data sets are on paper, files, mobile devices, WhatsApp, hospital EHR systems, and maybe not even existent, can you also educate us on how that will be useful going beyond policy, sir?
Okay, so what, as sir already mentioned that, the earlier it was fragmented, right? And via NHA, the schemes, we are trying to unify that data set, right? The idea of a patient, so that in ideal world, maybe in couple of months, let's say, for each patient, let's say we have unique ID. I mean, we already have, but it's pretty much linked to all of his other schemes. Now that data set, DPDP active, when I was mentioning about, if I'm processing that data, if I'm holding that data, so I'm holding that data within my physical premise of that hospital or taluka level, whichever the device I mentioned, right? So the person who is worried about the privacy, or the officer who is worried about the privacy, he knows that his data is sitting is next to, it's not going somewhere on the server. It's sitting next to supercomputer, which is in server. It's not going outside India. Rather, it's I mean within the physical boundaries. So that way, the local compute, edge compute addresses DPDP Act. I would say very directly.
Let me also add to it. When we talk of ABDM, here the privacy is by design. Let me clarify. When the data is generated, let's say in the hospital or in the laboratory or in the pharmacy, the electronic health record, it doesn't move from one to other place without the express consent of the patient. That is one. Second, in the whole ABDM system, where we maintain this gateway of health information exchange, there is no repository of the data. We don't migrate data from the hospitals to any kind of data lake or central repository. So data remains at the source where it was created, and it gets linked to the patient through his or her Abha ID, which he can see on the personal health record application on his mobile. So here, since the data doesn't actually migrate, doesn't reside in a central repository, there is no risk. Actually, every time you want to access the data, you need a consent. And since data is available only for usage you decide, so purpose limitation you make, application you deploy, and then it is the consent which the patient or the source which has generated gives. So this is how the ABDM by design itself complies the DPDP Act. And to a large extent, NHA itself has its own health data management policy, which makes sure that the data is completely private to the individual, and it is with his consent only it is shared across the health systems.
Yeah.
So I think it is something which India has created, and there are very few countries in the world who has created this architecture.
Yeah.
And now the challenge is to get more and more facilities or the hospitals to onboard on this.
Yeah.
So we have created the infrastructure first. Now let the adoption take place in a seamless way. Thank
Sir,
you.
can I add a little thing? So we have spoken about how secure systems are being built in India. We have not discussed the opportunity that we have created with it. So one of the biggest bottlenecks in health AI systems is secured longitudinal data sets with live touch points. And what we have, in essence, been able to create with ABDM is a framework which does ensure eventually longitudinal data sets being created and potentially live touch points being created, which can result in wonderful solutions like the SAMD being developed by you and several other disorders being diagnosed far earlier and tech being developed on it far earlier. So it's not just about how secure it is, but also the opportunity, a massive multi-trillion-dollar opportunity that we have created here.
Stop that, please. Yeah, no, thanks, Dr. Sabine. I'll probably take just one more question. We're really running out of time. One more question. Anyone? Yeah, here. Please, madam.
Thank you. I'm Snehada. I've been working in the healthcare sector for almost 15 years now. So, uh, thank you so much for a wonderful session. Ma'am, one point that you made triggered this question actually. The thing that you said, that the objective of healthcare is that we are more unhealthy, we are healthy rather than, that's the whole objective. And the screening part that you mentioned was again something which is so critical. Now, of course, a screening will happen only if the person or the people here are aware. How does AI not just increase, we are talking about the technology which does the detection, does the prediction, but how does AI can help us to create that awareness among people, which will reach us to that screening stage, which will actually trickle down the rest of the process?
Great. Great
Ananya, do
question.
you want to take this one?
So let me take you to Afghanistan for this, right? Because one of the most difficult environments to work in, right? Do I necessarily think that AI is the answer there? Can it help? Maybe, but I don't think that's the foundational answer, right? In Afghanistan, we ran healthcare for 5 cities, right? Including some of the names that you would have heard in the news, right? And we had a very simple phone call service that pregnant women who have already delivered babies along with their families could essentially call and get advice on, right? 98,000 women called those lines, right? 60% referred other women to call the line, right? Including family members, whether they were mothers-in-laws or whether they were sisters. And we had a north of 80% recall rate on the calls as well, right? So I don't think that AI needs to be the answer to everything, right? Can it help? Of course, it can supplement all of this stuff, but I think some of the basics and some of the foundational stuff you still need to be able to do. I think it's about democratizing access to information in a format that women want to consume. Right, in the way that they want to really look at it. I mean, if you're going to run a phone call line between 11 a.m. in the morning to 4 p.m. in the afternoon, believe me, no woman is going to access it, right? But if you give them access from 11 p.m. in the morning till 3 a.m. in the night, they will. Right?
So we call it IEC, right? I mean, and it is something as simple as putting a banner on a rickshaw and letting it run around the city, right? Some things very basic still work. It's always about first principle thinking. Look at who is your audience, right? It's basic management thinking, as we call it, right? And basically look at who is your audience, when are they going to be available, which are the avenues that they are going to listen to.
Yeah.
And those are the areas where you start decimating information. And any program or any product will only be successful if you are able to, as you said, educate early. But screening also works when you give a push. So healthcare as a practice should be a push versus pull. You should be able to push screening before someone actually feels the need for it. And that is where education is and will play a very, very pivotal part.
Thank you, Dr. Sabine. I think we are really running out of time now, and the organizers might want to kill me, so I'm going to stop here. But this was great having all these wonderful panelists. Thank you very much for a patient listening. I'm not going to summarize all of this. I don't think we have time, but thank you very much. Thank you. Thank you. Thank you, sir.